Hi, I'm Todd Barron, professor of medicine at the Mayo Clinic in Rochester, Minnesota, and I'm doing another author interview. And today's guest is Dr. Kulwinder, who's a professor of medicine from the Medical College of Wisconsin. And Dr. Dua is here to discuss with us his paper entitled Efficacy and Safety of Self-Expanding Metal Stents for Biliary Decompression in Patients Receiving Neoadjuvant Therapy for Pancreatic Cancer, a Prospective Study. Thank you for coming and welcome to the interview series. So tell us a little bit about your paper and a general overview.
Yeah, we conducted this study primarily because since early 2009 we shifted in giving neoadjuvant therapy to our patients with pancreatic cancer as against adjuvant therapy that we used to do before. Mm-hmm. And as you have written on this topic many times in the past, draining the bile duct in patients with cancer of the head of the pancreas is a non-issue if the patient is going for early surgery, which is the adjuvant therapy. Right. But when you give them neoadjuvant therapy, it takes around about anywhere from 3 to 5 months before they get to surgery. Mm-hmm. So durable bile duct drainage becomes a major issue in these patients. Mm-hmm. And interestingly, metal stents are not yet FDA cleared for patients with intentions for surgery having resectable or borderline resectable pancreatic cancer. So these patients then generally tend to get plastic stents placed in, usually 10 French. And the series that was reported from MD Anderson showed around 68% of these plastic stents occlude for whatever reasons, effect of radiotherapy on the plastic, lithogenic bile, infection in the bile from immunosuppression, but the occlusion rate is very high that required several reinterventions, cholangitis requiring hospital admissions and interruptions of therapy. So they were not ideal for neoadjuvant period. At the same time, metal stents have this fear that it may interfere with surgery. And although there is no scientific paper that clearly shows that surgery becomes difficult with metal stent, it is not used traditionally. So we, in our institute, by protocol, place, if you may, a short metal stent, that is stent long enough just to bridge the malignant stricture and not go up way into the bile duct so that our surgeons have difficulty for subsequent anastomosis. So with this approach, we have been, in all our consecutive patients, placing short metal stents during the neoadjuvant period. So we decided to prospectively study the efficacy, safety of this stent in resectable pancreatic cancer with intentions for surgery during neoadjuvant period.
Great. So were these covered or uncovered stents that you used?
Yeah, by protocol, we did not have any intentions of removing the stent prior to surgery. That's the point we were trying to make. And in that regard, we shied away from putting covered stents. In our series of about 55 patients, we only had 8 who had covered stents placed in. Others were all uncovered stents, and of course we would not like to put a covered stent in anybody who has got a gallbladder still in place. So majority of our patients had uncovered stents.
So I noted that about 60% of your patients ended up going for a Whipple procedure. So that means number one is about 40% of the patients this served for palliation. So those patients did extremely well. And you pointed out the less need for intervention. So I think what puts some people off is the cost of the stent, but clearly that's offset by the decrease in the number of procedures.
That's right.
So I think that's a very important point for people to realize, is that it makes, I think, a big difference from a cost standpoint, but also the patients don't get ill with cholangitis while they're in the middle of getting their treatment.
60% of them actually went in for a planned pancreatoduodenectomy. Emphasizes or underscores the point that we saved 40% from having a Whipple unnecessarily because they progressed.
Right, with therapy.
With therapy.
Yeah.
And this is one of the reasons those who give neoadjuvant therapy lobby for it, that you save unnecessary Whipple in patients who have either micrometastasis to begin with, have aggressive disease, or the comorbidity worsens during the treatment. And on the flip side, even though we say that resectable pancreatic cancer, the cure is surgery, we now know, if you may, that pancreas cancer is a systemic disease,
Right.
even though they may be resectable.
Right, and it's not really a curable disease.
Exactly.
at this
So
point.
they would require chemotherapy and chemoradiation. And if you look at the series that have come out from many centers, only 50% or so actually get adjuvant therapy, because after surgery they have a complication, they may have drop in their performance status,
Right.
comorbidities may worsen. So if you give the chemoradiation upfront, you are kind of guaranteeing 100% getting it
Right,
in a
right.
condition that is a systemic disease.
Right, right. So I know Jeff Lee had done a study where he actually compared retrospectively patients who got plastic stents and those that got metal stents, and found a difference. If you had to look now at his data that he did retrospectively to your prospective data in the metal stent arm, do you think that's fairly equivalent, the findings in those studies?
Yes, I think the metal stent, the issue now in our study is not how long the metal stents can stay open,
Right.
is can they stay open till the neoadjuvant period,
Right, right.
which in our study ranged from anywhere from 70 to 260 days.
Right.
So even if the metal stent performs not
Right.
that great in the long term,
Right.
it doesn't matter. For us, it is only this period.
Right. The goal is to get them through
Yeah.
the therapy. No,
Yeah.
I think that's a very good idea. Is there anything else you would like our readers to know about these patients in terms of expandable stents? Is there any problem with actually delivering chemo or radiation because of the stent?
Yeah, good point. The few things that came up is that does the metal interfere with radiation? The limited amount of heating that happens with the radiation was of no consequence in terms of treatment. The second thing that comes up is that if you have a patient who is going to get a follow-up imaging study after neoadjuvant therapy and cannot get a CAT scan, is it safe to put the stent in a patient who's going to get MRI scans? And being made of nitinol, this particular stent that we used is the Wallflex stent that is made of nitinol, and many other stents are also made of nitinol. They are okay as long as we use MRI scan lower than 3 Tesla units. And I think by and large we are way below that value. Okay. Another point that I would want to point out is that when we get the stent from the package and it says that it is 60 millimeters or 6 centimeters long, that is the fully expanded stent length. But sometimes the strictures are so tight that the stent may not fully expand, and the 60 millimeter long stent may actually, because it is not fully expanded, become 8 centimeters and land up in the hilum.
Yes.
Which then interferes with surgery.
Yes.
So keep that in mind, and what I technically do is that I take the stent, get a rough idea subjectively how the stricture is, deploy about maybe a centimeter of the stent near the hilum, keep the rest constrained, pull it down to give a centimeter or 2 centimeters of the bile duct for the surgeon, and then deploy the rest.
Yep.
So that I'm guaranteed that
right.
I'm giving space for my surgeon.
Right, right. How many of those patients do you think could have gotten away with a 4 centimeter long stent for their stricture, and obviously they wouldn't be above the bifurcation?
Yes, interestingly, as you noticed, that we used a fair amount of 4 centimeter long stents, and even if the stricture is say 3 centimeters long, and we tried to keep 1 centimeter above and 1 centimeter below, so hypothetically we should have selected a 6 centimeter long stent. But if that 4 doesn't expand fully, it becomes 6.
It'll never be 4.
Yeah, it'll never be 4.
I think that's a very important point, and I've had that happen as well. And so one of the arguments could be that you could use a non-foreshortening stent as the other option, which there is. All right, well, thank you again very much for coming and spending time with us and discussing your article, and have a great rest
and
of
I
your
want to
week.
thank gastrointestinal endoscopy for having given me this opportunity.
Yes, thank you.
Thank you.